Right. So what we can do here is we'll ask some of the faculty to provide input, but also if people want to just make comments on the chat, they usually show up at the bottom of the screen, and we'll just get a feel for sort of what people are thinking. I just want to go through one case. It's a pretty, in one way, a very commonplace case that we'll see all the time, but in another way, there are a lot of nuances and things that options for treatment that are pretty controversial. So this is a 58-year-old male. He's an Amish, which is a religious sect in North America that does not ascribe to technology. He's a farmer. He's a father of 11 kids. He was at a religious service in a barn. When the floor gave way underneath him, he landed first on a horse and then on the floor. He's stable. He's got a heart rate of 60. His blood pressure is 100/60. GCS 15, respiratory rate of 12. On his motor exam, he's got grade 3 biceps bilaterally, no distal motor function. He has gross touch sensation in bilateral lower extremity. This case was a few years ago where x-rays were relatively routine. And so here you can see this was a cone down view of his lateral x-ray. So first question I'd like to sort of throw out there, see what people have to say, is would you start steroids? And if you would, what protocol would you use?
Okay, the chat is on. You can answer this question there, please.
And if one of the moderators could just sort of read out what people are saying. Faculty, any of you would start steroids or would you avoid them?
Hey, Doug, this is Mike. This is a 58-year-old guy, you know, probably has some degree of comorbidity. I think we differentiate this from the 18-year-old with acute spinal cord injury. I say that simply as backing up my argument that I would not start steroids on him.
So a majority of the people are saying no on the chat. Only a couple of people have said yes.
We never use steroids here.
I'd be interested to know if Mike Failings is still on what his opinion is. Are you there, Mike? I guess not. Okay. In this particular case, the patient had been started on steroids at an outside institution, and on arrival at ours, we actually stopped them. We did not believe that that was appropriate. So what other imaging do you want to get at this stage, or do you want to just move right on to treatment? You have a 58-year-old male with an incomplete spinal cord injury and bilateral jump facets.
Okay. CT scan,
Doug,
MRI.
Are we asking as well, or do we?
What we'll do is we'll see what what happens on the chat to get an idea of what the audience is saying. But also we can, you know, the faculty can feel free to chime in on what investigations they think they would want to do, or would they just start treatment?
So Doug, if it was me, I'd probably get a CT scan and you know, consider, you know, either getting to the operating room quickly or put the patient in traction. I think the controversy here, and I think this is why you brought this up, is, you know, MRI. You know, if I could get and kind of like if my center was set up that I could get a CT MRI kind of immediately, I would do both. If there was an MRI delay like you and I have at the Cleveland Clinic, then I would probably get CT scan and use that for planning and maybe hold off on MRI. But if I could get an MRI right away, I think I would do that.
Any other thoughts, people?
I totally agree. Doug, that's what you do as well, because we have the facility and we can get both of them very quick. So we do both of them, and so we have information on everything before we do anything. Obviously, if there's any delay, there's somebody in MRI or somebody in CT, then, you know, we straight away do whatever is required in emergency. Can you show us the film again, please?
Okay, so, you know, the one thing, you know, in an awake cooperative patient, there is no reason this has to be linear. So what, credit to Rick Fox from Edmonton. Rick developed an attachment for a spine board that allows you to put traction on a spine board and then transport the patient with the traction so they can go straight into the MRI scanner or the CT scanner or whatever you wanted to do. So we actually started, I mean, we put this guy in Gardner Wells tongs and it started hanging weight on him basically as soon as we had the x-ray, with the hope of trying to get him reduced. And then we did, at the particular institution where this was done, the MRI scanner was on the other side of the hospital. The CT scanner was right beside the ED. And so we just went and got the CT scan. And so here you can see the CT scan. As you can tell by the quality of the sagittal, this was an older single detector, not maybe the best quality. But does anybody see anything that makes them a little concerned looking at this in terms of what the treatment options next would be?
Obviously, the problem could be the vertebrals could be involved, so they need to be looked into as well in this particular case.
That would be one. That was one option. That's why I listed MRA, or angio initially. But I'm just thinking in terms of treatment options, where you're going to go from here. Is there anything that concerns people? Because I know when I saw this CT, there was something that concerned me.
So CT
So
and
Doug, you with this high degree of spondylolisthesis, you're thinking that this patient, either has bilateral jump facets or fracture dislocation.
So yeah, what he had was the rest of the CT. I didn't throw it all in here. He had a unilateral facet fracture and a dislocation on the other side.
Yeah, and I think what's concerning here in my mind are a couple things. One is, I'm trying to plan my reduction. This guy's older and has a lot of spondylosis, so I'm thinking how is that going to impact my treatment? And then you've got this hyperdensity behind the bone,
yeah,
on your sagittal. So is that a piece of bone that's fractured? Is that that what is that, and how will that impact my reduction? So I'm thinking in my mind, I'm trying to understand what that is.
What that turned out to be was a big piece of osteophyte with annulus and disc attached.
So again, may impact your overall ability to reduce this. And you're also thinking, again, if you're not going to MRI, is that a big piece of mass behind the bone? And should I be doing this anteriorly so I can decompress that first before trying to reduce? So I think in my mind, that's what's going through me, is like, how am I going to reduce it? How am I going to do it safely without injuring this person? I don't have an MRI. How will that impact me? And I may be more concerned about trying to do this posteriorly only, asleep, with that bone and everything behind the body.
That was our thought process. Is I was uncomfortable with that fragment being there, doing a closed reduction, in an operative closed reduction and posterior fixation. I wanted to deal with that fragment, and so that was the decision making, is that we decided in this particular case we wanted to go anteriorly to address it. And so, then sort of where it went from there. Oh, sorry. So the options again, what do people think?
Can I say something about the closed reduction?
Sure.
In fact, actually, it was an old tradition to make closed reductions in almost all cases.
Yeah.
Then in the recent analysis, we could not find a big difference in the outcomes between open reduction and closed reduction. So we must be cautious for recommending to any patient closed reduction. Yeah,
I think in an awake cooperative patient, which this guy was, I think closed reduction is a very good option. And so what we did essentially is we sort of proceeded along parallel tracks. We started doing a closed reduction. Now we did not, at this time, we were not doing manipulative closed reduction. A lot of places now, a lot of people are starting to do fluoroscopically guided manipulative closed reduction. At this time, the protocol was, traction. So we actually started, and what we did is we pursued parallel tracks. We told the OR we wanted to bring the guy up to do surgery. And while we were waiting to get an OR room, we were hanging weight off of him and see if it would reduce. And that was sort of, again, my point with a lot of these. We talk about, what's the, which one is better, which one do you go to? And particularly when it comes in an awake cooperative patient, the waiting to do closed reduction or till you get imaging done, you can actually go ahead with start your closed reduction before you have your more definitive studies, because in a guy like this who has a partial neurologic injury, I think the key is get them reduced however you do it as quickly as possible. Other thoughts?
Yeah. In this instance, my intention would be immediate operating room for anti-reduction and fusion.
Okay.
Yeah.
All right.
You.
So anyway, that's what we did. We got, we did basically, we started the closed reduction. We were delayed by by a cardiac surgery case that took us a little longer to get to the room. So we began with the anterior discectomy and reduction. And you can see this is what we got. Thoughts?
So Doug, what I would be concerned about here is you've got a great reduction, and you've got it stabilized with a plate, which is, point of fixation above and below, but it looks like you've got fairly, you said you did this all anterior, you did it anterior posterior. There's a lot of gapping in the facet joints posteriorly.
The goal was to try and do this anteriorly, and we screwed up.
Yeah, I would be worried about stability there with the plate. I know that we get away with this a lot, but this is one that could, with a flexion moment, could dislocate again. You just relocated the facets.
Our error here was twofold. We probably should have shaped the graft better and had a more lordotic graft, and I think we overstuffed. This was a guy who was pretty spondylotic. And in these bilateral jump facets, it's easy to put in too big a graft, and I think that was our mistake. We overstuffed this graft. So on seeing this X-ray, I agree. I was not happy with that X-ray. I was not willing to let that one go, and so we immediately went and did a posterior fixation as well, just because I was not going to rely. If you have contact in the facets, I think an anterior only implant with a failed posterior tension band is okay, because I think the facets provide that tension band. But no, I just was not willing to accept that gap in the facets, and I agree with you, Mike, and that's what we did. Comments, questions?
Actually, good thing you have done. What I was recommending, starting from the ventral instead of dorsal. In all acute cases, it's better to start from ventral.
I think so. I prefer the ventral, and if I can get good contact in the facets, I just do the ventral. I tend to use a fixed angle device. Fixation
is a discussion still. Sometimes you can not do it. You just leave it this way and place the patient in a rigid collar for long periods. Yeah. And follow the patient. Mm-hmm. It's possible. Both are okay.
Yeah. Okay.
If this was an old case, would you start from anteriorly as well, or from posterior?
Sorry, by an old case, do you mean?
Like 6 weeks or something like that.
6 weeks?
So,
oh yeah. Man, 6 weeks. Yeah, if you have somebody that you're treating delayed. Basically the key there is what does things look like on the CT, because I've seen everything from things are still really mobile to patients who have like spot welded fusions in the facets so that they're not going to reduce from the front because the facets are fixed, to fused in the front, and it really depends on what's fused and what isn't. My preference in one that's delayed is probably to go from the back, as long as there isn't an anterior fusion. And if there's an anterior fusion, then it's just dealer's choice whether you go front back front or back front back. But I think you end up doing it from both directions.
Excellent case, Doug. Really enjoyed that.